Yeah. Thank you for the invitation and the introduction. So I'm just going to show you just three cases. Actually, my presentation is very simple, and it's just for us to learn some points here. So you can ask questions, you can stop, you can give your ideas as well. So okay, yeah. So the first case is actually a 57-year-old male. Okay, and it's got triple vessel disease. We did his RCA and excuse me, and after that he had a very diffusely diseased circumflex which we ballooned, a drug balloon, and we then proceeded to do the posture of the LED at the same time. My slides don't seem to work, they stop. Okay, so we did the circumflex, and then if you notice, okay, he actually has a short left main. All right. Okay, and so we're actually very well aware of this. Okay, we wired the LED. Our intention is actually to do the Austrian LED stenting. Okay, yeah, I mean, okay. So we wired the LED, and he's actually got two diagonals. I'm sorry, the images don't work. They told me it worked before that. I sent it in earlier, and so what we did was we wired the D2. We pulled the circumflex wire back, okay, and we ballooned. We used very small balloon, okay, and finally we got what we wanted. Now, we were actually very well aware that because the left main is short, we were very well aware that there was a possibility of longitudinal stent deformation. And so we were very careful. We put a stent, okay, as you can see in the right one, is supposed to be moving as well, okay, and we pulled the D2 wire back very carefully, okay. And we went to great I mean, planning to actually ensure that we don't damage the stent, okay. And then we actually inflated, and then you see, we even pull the balloon, the stent balloon back very carefully in the left picture, okay. And well okay, in the right picture you're supposed to see haziness of the stent, okay. Now the what happened was, as you can see, after we pull the balloon out, I wanted to test to see whether the diagonal wire was strapped. So actually, it was strapped. So I put it up very carefully. We were very careful. We used the circumflex wire to actually prevent the catheter from going in. And finally, what you saw, I'm sorry, the images are not in synchrony here. It's not working. And finally, what you see is we saw a bit of haziness, and I wanted to do an NC, and I couldn't pass the balloon. Okay. And we have stent boost, and you can see what you actually see there is, well, the stent is damaged. Okay. Now, at this point in time, okay, first thing is you see whether the patient is stable or not stable. All right. Check your ACT. Okay. The most important thing is, again, never ever lose your wire. Never lose your wire. What happens is, a lot of us, we tend to force, and we force like the earlier complication session, everything, the whole system came out. Okay, don't. So plan, think, patient stable, not stable, not stable, do whatever you need to do. Patient stable, you have time. Okay. And so what we did was, we went and we downsized our balloon. We took a 1.5, and fortunately it went in. Okay. And then finally we did many balloons. We used many sizes, we used many IVUS runs, okay, to expand this very carefully. We kept checking the ACT. All right. Okay. Now, very importantly, when you have a proximal, well, it's always proximal, longitudinal stent deformation. When you pass your balloon in and you pull, you actually pass your balloon in, you pull your balloon back slowly, and you start inflating from the distal part of the deformation to the proximal part, not from the proximal part, because you want to open it up and flare it up again. All right. And so this is what we did. And after we got all the images, this is the final picture. All right. So, well, you can see actually very nice image. Okay, but unfortunately you can't see it. Now this is a very stressful case, because this particular patient is actually a renowned ENT surgeon, and it's very stressful. He's our colleague. He's very well known, and of course, as you know, when you do doctors, you get complications. Okay. So but the point to learn here is, never ever lose your wire. Okay. It may not be very common, but, and we know, we knew all this. We knew the left main was short. We knew that, not to get the wire. We knew what to do, but still we got a longitudinal stent deformation. Okay, and always, if you have to call for help, just call for help. Hopefully the second case works. Okay, so the second case is a 56-year-old man. Again, a different kind of stress. He's got a very large circumflex, and I did his RCA in 2011. I put in a stent. Came back with some shortness of breath, as you can see, and there's a bit of ISR there. I said, okay, fine, okay, very straightforward case. This is my fourth case of the day. The first three were very, very complicated. This is actually a very straightforward case. I'm always very careful, okay, slides don't work, okay. So I passed a balloon, as you can see in the left scene there, okay. I'm inflating the balloon goes down very carefully, okay, and it slips, so the lesion is tight. Now, at this point in time, okay, so my catheter is a no side hole catheter. At this point in time, the technician who was covering me that day is actually a very quiet person. He's a very nice, very quiet person. And he kept saying no pressure. I didn't understand what he was saying. No pressure. I said, okay, very funny. But I had no side hole there. And it's a very straightforward, easy wiring, easily balloon. You can see yourself. And at that point in time, the whole hemodynamics, the ECG. So I pulled the catheter back. The pressure was still like wavering just like that. But then the ECG tracing also vanished. I didn't know what happened, okay? I fluoroed. That was let me just go back to see whether it works. Okay, so this is, okay, so it's supposed to work. So this is what you get. You get staining there, okay? You get some form of dissection. There's no stenting, nothing, okay? So I didn't know what was going on. He was very quiet. Again, look at the patient. Stable, unstable. Patient had chest pain. Well, I don't know whether he's stable because there's no pressure. Okay, but had chest pain. So immediately, fine. What we did, we took an echocardiogram. Okay, we saw aortic root, no dissection flap, at least no pericardial effusion. We checked the ACT. At that point in time, I made a very big mistake because I didn't know what was going on. I pulled the wire back. So the first case, I didn't get the wire. I refused to pull the wire back. I maintained my wire. Here, I made a mistake. I pulled the wire back out of frustration because I didn't know what was going on. There was no pressure well. There was no pressure well. There's a dissection there because there's no side hole. But there was no ECG tracing. Well, it's no one's fault. It just went off. No one's fault. Okay. But I didn't know what was going on. It's just bad luck, bad timing. I pulled the wire back. Okay. After that, nothing I could do. I couldn't, I changed different catheters, different wires, different balloons, okay, nothing, I lost, okay. So my actions made it worse, the flow was worse, okay. So finally, well, I said, I'm sorry, I accepted defeat. I sent the patient to the ICU. We got an urgent CT scan, we got everyone in, there was no dissection, we kept him there. I told the family members I made a mistake. I was very humble, very honest. I bowed to them, and they were foreigners. They are actually from Myanmar, and I'm Malaysian, of course. So it doesn't look good, when someone comes to your country and then you mess things up. So, well, finally I kept him on medication. 3 months later, I said, okay, bring him back. I decided to do a femoral access, just a catheter, and this is what I got. And I saw there was enough flow there. Okay, my courage didn't allow me to progress. I didn't want to engage the catheter. You can see there's a flap. I think there's probably a healing flap there. I didn't want to progress further. I saw good flow. His echo was still fine. I said, stop. Okay, now, unfortunately, a lot of time wasted. Case number 3, highly symptomatic patient, okay, a lot of chest pain. 1 week prior, we could not pass there's a mid-LED, okay, what to do? I accept defeat to my slides also. Okay, so yeah, so we were not able to pass the balloons on the LED. So what we did was we listed him a week later, do a rotablation. We couldn't pass the 1.5 burr down. Okay, finally we couldn't pass the myocatheter. We took a risk, and then finally as we wanted to actually downgrade the burr to 1.5, suddenly the patient had very severe chest pain. Okay. And what you see here, sorry guys, a lot of work done but all wasted. Okay, so there was no flow, okay, in the LED. So when after rotablation, so when there's no flow in the LED, okay, Well, again, see patient stable, unstable. Patient was in severe chest pain, but the vital stable. We put a pacing wire there. So when you do rotor ablation, you think of a few things, whether it's thrombus, dissection, spasm, no reflow, and all our planning, everything went well, but we forgot to check the ACT. And the ACT was 189, and the patient actually had thrombus. If you had seen the picture there, you can, and it's actually a very nice picture. We obliterated, there you can see. So there's thrombus there. Wait, just give me a minute. Okay, yeah, sorry, my, wait. Yeah, you can see thrombus there, septal gone, diagonal flow down. So what we did was we gave a lot of GTN, we gave heparin, we just waited, we just waited, and the flow came back. Okay, we did nothing, the flow came back. Okay, there you can see. Then we continued with our rotor ablation, we DCB the LAD and the diagonal, and this is what we left it. So we bring the patient back. Okay, and I don't think I have enough time. Let me go to the last two slides. I'm sorry. Okay, so when you deal with complications, first of all, you try to prevent them. If you can't prevent them, you can anticipate at the longitudinal stent deformation, then you take precautions lah. And if you have a complication, then you treat. Okay, and complications, the more complex coronary intervention you do, well, more complicated cases, complications you get lah. So in summary, intervention. What is success intervention? Success intervention is not complex angioplasty. Success intervention is safety, which comes from detailed planning after good training. Okay, what is failure in intervention? Failure in intervention is actually not complications. Okay, it is learning from your setbacks and complications. Despite detailed planning, embrace your complications. All right. Thank you. I'm very sorry about the slides.
So thank you, Ramesh, for the a lot of interesting case. And usually we always got a complication of IT when we present a complication. So I think it's true. So I still need one or two comment from the panelists. Tony?
Thank you, Ramesh. We learned a lot from your cases. And then for the first case, I think it's a very important lesson for us. First, if you deal with the very short left main, first, I think the choice of picking the guiding catheter is really important. So very short left main, I think maybe the Judkin left much safer comparing the extra backup catheter. Because the chance of getting pushed a little bit lower, like your case, and then secondly, to avoid the proximal deformation, I think it's also make sure that when you retract whatever inside, especially the balloon, you are fully deflated. Sometimes if you working with a fellow, and fellow just take out everything just before the balloon well deflated, so that's also. Okay. Yeah, I also did that. Okay, all right. And then the last one, I think in the very ostial stenosis, sometimes when I retract the balloon, not exactly directly to retract, I push a little bit so my guiding catheter go outside a little bit, and then retract really careful. Anyway, but we learned a lot from your cases. Thank you very much.